Tisha, may I please invite you for that?
Thank you, sir. Thank you so much. Now, I would like to introduce our first panel of the day. So, let's start with Dr. D.K. Gupta, Chairman and Managing Director, Felix Hospital, Noida. Dr. Alok Rai, Chairman and MD, Medica Group of Hospitals. Namit Soni, sir, CEO, Soni Hospitals, Thane. Dr. Vundavali Suri Raju, Managing Director, Regal Hospitals. Adarsh Somashekhar Sir, Chairman and Managing Director, Ovam Hospital. Ms. Neha Lal, Senior GM, Operation and HR, GCS Medical College Hospital and Research Center. And Ms. Lal is also the session moderator. So over to you, Ms. Lal.
So very good morning to all the eminent speaker. I feel so privileged to be here on this platform among very big giant of the healthcare industry. And today's session is going to be very, very interesting. So with a little bit of background on healthcare industry is that, as you know, that healthcare has become one of India's largest sector, both in terms of revenue and employment. Healthcare comprises all hospital, medical device, pharma companies, CROs, and outsourcing and telemedicine and medical tourism, insurance, medical equipment companies. So these are all growing at the brisk pace due to its strengthening coverages, services, and the increasing expenditure by public as well as the private. I'll just throw some data which we have, which has just happened post-COVID as far as healthcare market is concerned. That is, the healthcare market already has increased threefold to rupees 8.6 trillion by 2022. In the budget 2021, India's public expenditure on the healthcare stood 1.2% of GDP, which is remarkable. There are two government initiatives. I just take the reference, and this has been taken for the healthcare industry in the recent years. That is, in September 2021, Prime Minister Narendra Modi launched the Ayushman Bharat Digital Yojana. That is mission. This mission will connect all the digital health solutions of hospital across the country with each other, by which every citizen will now get a digital ID, and their health record will be digitally protected. That is the biggest move. According to the other spokesperson, the Indian government is planning to introduce a credit incentive program worth rupees 500 billion to boost the country's health infrastructure. And the program will also allow firms to leverage the fund to expand health facility or medical supplies, with the government acting a guarantor and strengthen COVID-19 related health infrastructure in a smaller towns. In June 2021, Union Ministry of Health and Family Welfare, in the partnership with the UNICEF, had a capacity building workshop for media professionals and health correspondents in the northern eastern states of India on the COVID-19 situation and the need to boost a myth regarding COVID-19 vaccine and vaccinations, and to reinforce the importance of the COVID-19. So we have a lot of data which is available, what all initiatives government has taken for both the players, public as well as private, and many new initiatives and the schemes and missions have been launched by the government. So the road ahead is India is full of opportunities for the players in the medical devices industry. The country is also one of the biggest, leading destination for the high-end diagnostic services, with a tremendous capital investment for Making India project. India medical devices for consumers have become more conscious toward their healthcare backup. With that data, I just opened today's session, which has the background of healthcare system needs to have a balanced infrastructure with the technology and to the human touch to provide the satisfactory services to the customer. The current healthcare Indian structure is undergoing the revamping and whole new environment for all the people, all the community, let's say post-COVID. So we would just like to interact with all these distinguished speakers here on the healthcare infrastructure, on the initiatives taken, and what is a roadmap for the further development. So we'll start with that. My first point to Dr. D.K. Gupta, sir, from the Felix Hospital. Sir, what are your views when, healthcare cost is increasing, as we know, that how can Indian healthcare, system to ensure the top-notch healthcare services is made available to the people, to the community who are coming in the rural background, where, the access of the healthcare is always issue. There is an issue of affordability, there is an issue of accessibility. So what are your thoughts to address this particular point? Sir, you'll have to unmute yourself, please. Yeah.
Thank you so much for inviting me, and I'm really thankful to the team. I would like to tell you that we all know that about 70% of our population is residing in the rural area, and only 30% is residing in this urban area or tier 1 or tier 2 cities.
Sure.
However, paradox is 70% of healthcare infra is consistently is confined to this tier 1 and tier 2 cities only, and primary healthcare, even secondary and tertiary healthcare, they are not being accessible properly to these residents who are in rural area, around 70% of population.
Sure.
We talk about the expenditure, budget allocation to the healthcare sector. Indian government for last 70 years, they were investing around 1 to 1.2% of their GDP, as you already told us, and it is among the lowest in the world. Even WHO says it should be 5%. BRICS country, excluding India, they invest around 5%. And if we talk about the developed countries like US, Canada, Italy, and European countries, they invest between 10 to 15% of their GDP.
Oh.
And if we talk about the investment in the healthcare by the private and public sector, 90% of the healthcare investment in these developed countries by government only.
Sure.
And most of the healthcare services are provided free of cost too. They're all insured. However, in India, it is dominated by 70% beds, doctors, nurses. They are provided by healthcare providers. These healthcare providers are come from the private healthcare providers only. Means healthcare industry, that is around $3 billion industry in India. It is dominated by purely by healthcare providers, those who are come from private sector. It means we have to somehow strengthen the private sector also, and we have to expand we have to increase our GDP allocation to the healthcare sector also.
Sure.
Normally, this government already has been done that healthcare spend has been increased from 1.2 to 2.5%, and government has vision to increase it to up to 5% by 2025. That is on the way, but still we need something more than that from government side to improve the allocation of budget to the healthcare sector. Number two, if we talk about the private healthcare providers, as I have already told you, that 70% of services are being into OPD services, indoor services, diagnosis services, pharma. They are all provided by the private healthcare providers. And the problem for us is that we have very poor recovery from these government panels, being it CGHS or ESI or ECHS, any government panel, any government PSU, they are very slow, like providing our bills, clearing our bills. So I think that has to be strengthened. Second, if we have talked about the rates of these, CGHS rates has not been revised for last more than 7 years. Ayushman rates are not viable. We cannot work on Ayushman rates if we want to provide quality healthcare services to our rural area. If they have made only on variable cost, they thought that infra doesn't cost to hospitals, human manpower, doctors don't cost to the healthcare providers. Only based on the medical consumables or only on variable cost, these packages has been designed.
Yeah.
So there should be a revision of these packages from Ayushman, revision of rates of CGHS rates. Can you believe that doctor fees is 150 rupees for DM or MCH or MS or MD doctor who's having over 10 or 15 years experience? So I think there are so many flaws in the rate list of this CGHS and also Ayushman. Also capping, there are cappings has been done for most of the packaging has been done. But the packaging is not rational. It should be rational. It should be intelligent price capping. We are in favoring of packaging and of price capping, but it should be intelligent. It should not be based on only on variable cost. It should also incorporate some part of fixed cost also, like fixed cost, infra cost, light cost, nursing cost, human resources cost. I think these things has to be worked on. If we talk about strengthening our providing good healthcare services to rural area, definitely preventive, primary and secondary care has to be strengthened. And for that, we have to go physical, means physical presence should be there through primary healthcare services, and digital also through telemedicines or even incorporation of artificial intelligence, AI should be there, especially for skin diseases, diabetic retinopathy, for radiology, as our like speaker has already told us regarding radiology services, because radiologists are very less and we cannot go to tier 2 and tier 3 cities to provide radiological services. So AI should be incorporated, digital transformation should be there so that we can provide primary quality healthcare services at their doorstep. And secondary healthcare services should be strengthened in tier 2 and tier 3 cities. Medical colleges should be open. Land allocation for private sector should be easy. Funding should be easy. Financing should be easy. Rate of interest should be there. Subsidies should be there. Even the licenses, you should know that we require around 28, 29 licenses to run a hospital in different parts of this country, and there is a huge time required, licensing is required, money is required. I think this should be one window platform. Even wherever there is a one window platform, still there is a manual intervention, and then we have to go physically and we have to please them. So that's why I'm telling you, it's basically all licenses to run a primary, secondary or tertiary healthcare services, they should be from single window with a fixed stat turnaround time, so that we should ensure that as early as we can get these insurances. Insurance penetration is quite poor. We knew that in COVID, we know whosoever were not having insurance, they were not able to get treatment also. Even in India right now, 62% of Indians are spending out of pocket to get their treatment. For that, they have to take loan from relatives and friends. They have to sell their lands. Even they have to sell their jewelries also. So for that, insurance penetration, including private and government, both should be increased in tier 2, tier 3, even in rural area. I think these are all main points. Even infra should be well developed in tier 2, tier 3, so that nurses, doctors should be ready to go in these cities to provide their services. I think if we all allocate all these points and we do work on these points and improve these points, definitely we will be able to provide good quality healthcare services to all, especially for rural area.
Yeah, sure. So, sir, you have actually touched upon very important agenda. I would say the challenges of the healthcare per se and what the government should look after. One important point about the Ayushman Bharat, because that's a big boon, but I think the affordability of that packages, and I would say the rationalization of the packages is very much required. It is actually now the agenda of the nation, because most of the state government, of course, the health is a state agenda, but all the states, BJP states have taken PMJY, and that is like whole India, and all the community and citizen is involved in PMJY. And a hospital like us, medical college, teaching hospital, trust hospital, I mean, they have to have the PMJY, because all the mid-size, medium income group, I mean, they have the PMJY card, and the BPL have the PMJY card. That was the vision of the Prime Minister, and that is how it is running. But yes, I totally agree that the payment coming from the insurance, payment coming from the government or state government or PMJY, that is too huge. And I think up till now, even the private hospitals are suffering for the payment of COVID. That's a lot of corporations have taken, initiative to support the COVID expenditure. Still, there are crores and crores are pending for the payment. So we totally agree with that. With that, the best message is to increase the contribution from 1.5 to 5% for the India, and that is indeed a need for the nation like us. So thank you so much for giving a lot of good insights which can be taken. I request Mr. Chandan to please note all these agenda and take it up to best and fullest manner. So moving on, sir, I request Dr. Alok Roy, sir. Sir, one point Dr. Gupta has suggested about the packages. So in that particular line, what are your suggestions? How can we build a kind of a treatment packages which is equitable distribution for all the community, let's say, based on the customer demand post-COVID? So we have got the capping on the packages. We have the CGHS packages which have not been revised. PMJY are totally packages which cannot be afforded by any of the hospitals. I'm talking on my hospital. We also cannot afford, compare about the private and corporate hospitals where the margin is there. And as we know, the cost of doctor, cost of nurses, as such, they are, I would say, under-empowered. So thinking of all qualified healthcare professionals around us, how do we address this issue? And what are your suggestions to build up packages in such a way which can be considered by the government?
Namaskar. Thank you for inviting me to ArdorComm this conference. First of all, I will request others to put themselves on mute. I think the Batra Group,
a lot of noise.
Batra Group, the CIO he should put him in. Thank you very much. That's very kind of you. So, Ms. Lal,
yes,
I agree that the packages have never been in favor of private healthcare providers traditionally.
Yeah.
If you see last 20-25 years, since I've been practicing healthcare and running it, some of the big hospitals, there was always something missing when they came to calculate the right value to a package. They had their logic was that we are providing you numbers. And we had our logic that it doesn't fulfill the basic criteria. And over a period of time, the gap has widened, as Dr. Gupta has said that 150 rupees doctor's fees. Fine, we agree. But our struggle with the government is ongoing. That struggle will not stop. We will have to constantly, and if my sources are correct, NHA has been given a mandate where they've got one of the senior person who's sitting in PGI Chandigarh who's trying to calculate the health economics and how much packages will cost. And probably end of this month, by 31st March, they have to submit. And once they submit the report, there would be upward revision of many rates which are very, very unviable for private sector. So that would give us some kind of breathing space. And once that comes up, then we can also go back to the government and talk to them about CGHS rate revision, upward revision, because there are some 2014 or some 2008 rates are still prevailing. Fine, that's something which needs to be done. But now the more and more third-party payments have stepped in. The very fact that PMJ, all rates are not bad. A lot of rates are very good. Yeah, medical rates are bad. So sweeping them with one broom, saying that all rates are bad may not be a very fair statement to the government. But the fair thing would be to say that some of them are good, some of them are bad. So they need to really look at it and bring it to a level where it's a viable option. Because private sector also, we use this government scheme as a filler, as a fuel rod. Whenever we have a low on the TPA and cash, we use them to service them, and that way we survive this. It's a win-win for both. Having said that, I would like to put in some thought. There are a lot of leaders here sitting here in their mind, if I succeed in just planting the seed, that you need to come up with an answer where you have to build affordability in the masses by using some unique, innovative methods. A lot of funding, like to give an example, a lot of finance companies are available which are saying that if you have a patient who can't afford, refer them to us, we will fund them and deduct it from them. Like EMI, you buy a car, you buy a cardiac surgery. So those innovative methods are coming in. Then the societies can pool money. We all can raise some funds. We need to come up with some methods where we empower people at large to access our care at a cost which is affordable to them. And it's a kind of like Impact Guru which has come now.
Yeah.
They raise funds. I have a doctor whose mother is admitted, and we have contacted Impact Guru to raise funds for it. So various methods of mopping up funds will have to be found out.
Okay.
See, the cost has only gone south in last 30, 40 years. Keeps on going south, keeps on going up and up and up. No cost goes down eventually. Doctor's price goes up. We were, when we started our career, we were given 25,000 rupees. We thought we are rich. Today you give 2.5 lakh rupees and still may not join you. So lives have changed dramatically and will keep on changing. We need to find new ways and methods. Just drubbing government that they are not able to give it, telling people they're not, like to DPS have not revised their rates in the last 2 years. They may not revise because there was a COVID, then they will wait probably for some more time. So I think we all need to, like we have found out the ways, innovative ways of surviving in this COVID, we must find innovative ways of surviving financially. And at the end of the day, we are here to serve the larger population of the country. Whatever it takes to serve them, we should come together and do that. That's what I like to say, Mr.
Sure, sir. I think your views were actually thought-provoking. When we are talking about one side, you have actually shown some ways as to how to balance the government expectation versus community. And the three main points which I have noted is about having the innovative ways to manage the healthcare cost we take. Of course, we can utilize the AI-based solutions. We can reach out to the market. There are a lot of funding agencies available. There are a lot of investment companies out there they would like to invest. I think those paths will have to be clear and explored upon. And the third important is to empower major community, major group of people where they can understand the sensibility of the healthcare requirements, healthcare needs for the community, and they can do something about hospitals, healthcare facilities in rural area, in urban area, wherever it is. So I think I request Mr. CEO, Mr. Chandan, also to keep on noting such important points, which are actually the takeaways from this particular session, and making a note as a concise note out of this session. Thank you so very much, sir, for sharing your thoughts. Moving ahead, as we talk about issues as well as some innovative solution from the thoughts, and then the one which point attract to my mind is about the AI enabled solution. So we have Mr. Namit Soni, CEO from Jaipur Soni Hospitals. Sir, what are your views? How can technologies like AI, because as we see, the healthcare has become hybrid. I would not say it's totally, telemedicine is totally virtual, but actually few of the patients still would like to see doctors in the hospital. We have to run hospital as well. So few of the services are available online, few of the services are available at the base hospital. We would also like to see our patients, physically. Doctors would like to see the patients physically. So I would say it's a kind of a hybrid model, which is kind of prevailing in this particular year. And we never know when the fourth wave of COVID would come, and that is expected, as I heard, in month of July or so. So having all these challenges besides, and you heading Soni Hospital, what are your thoughts? How can we leverage on the AI benefit solutions in such a higher expectation of the consumer and customers? Sir, over to you.
Hi, good morning to all, especially my August panelists here. It's a pleasure to be on this platform. So it's quite appropriate that you asked me this question, because 2 months back we have just installed India's first AI-based MRI machine in our city of Jaipur.
Oh, wow.
It's a first for us nationally. We're just in the process of inaugurating that center. We've done it in PPP project with the government of Rajasthan in Soni SMS Medical College. So I like to take two parts of it. First, try to share with everyone the view on how technology really makes an impact in healthcare, because definitely there are some generic benefits. But if you look at in terms of specific to healthcare, where and this COVID pandemic has given us an acceleration into technology adoption, where it is making major impact is in helping us lowering our costs. Whether it is in terms of operations, whether it is in terms of in terms of the care that we give, or whether it is in terms of the reach to our patients. Technology has really helped us to bring our costs down. Then through digital, our reach has increased, where our patients, even with our patients, if they're even 200 kilometers away, they can actually follow up on their treatment and be more you can say resilient in the treatment. Otherwise, because of the costs associated, and we being a slightly on the poor side of with most of the patients, it was difficult for the patient to travel again and again to the hospital, and there used to be a lot of dropout. So that reach and that digital dispensation is really playing a very important role in shaping how healthcare is changing going forward. And last but not the last most important thing is the patient-doctor communication. Today, if you see how the doctors are communicating with the patient, the biggest challenge for us is how we can smoothly communicate our complete treatment to the patient, and we can share that treatment. Today, with WhatsApp coming into picture, we can share everything, the prescription, the booking. The fact is self-registration. Today, a patient doesn't need to wait at your reception counter. He can register himself and walk in directly to the chamber. So the kind of patient-doctor relationship is going through a major change. So, and taking all that into perspective, AI part is going to play a major role. I shared with you right now how we have installed an MRI machine.
Yeah.
Now, where that will make a difference is the image acquisition. Today, we plan to do an MRI in less than 7 minutes. And I don't mean just the sequences. I mean the complete scan with patient moving in, moving out, thanks to this technology, because the machine is so advanced that uh, it will cap it it will slow down the scan if it finds that there is any abnormality, and it will speed up the scan if it finds that the scan is normal while the scan is happening. I mean, that is only possible thanks to AI. So we are moving in an era where computation, data analytics will really help us to move and provide care at a more affordable level and to more people. Whether you look at our own centers, I'm sure there are very respected administrators and MDs and founders here on this panel. They'll agree with me that the kind of patient data that we have, the 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 details in the patient data, if we start studying that data and helping them better in giving, whether it is designing packages for them, designing follow-up clinics for them, that has changed the way we give our treatment. So data and AI, the power to analyze that data is changing how we deliver healthcare to, and it is making it better for the patient and for the doctor. So it's a win-win for everybody. So, and one last point I want to share here for everyone is that AI seems like a very big black box to all of us, because we talk AI, but we don't understand AI. But the biggest thing is that if we start small, I want to take the example of PMJY that people are talking of, the Ayushman scheme. So Rajasthan has implemented a similar scheme in 2016, and it has gone through 4 iterations every year. And in the last 6 years, it has gone through 4 iterations. And right now, it is called Mukhyamantri Chiranjeevi Yojana scheme.
Yeah. So earlier it was Bhamasha, I believe.
It was Bhamasha, then it became Ayushman, then it became Mahatma Gandhi Ayushman, and became Mukhyamantri Chiranjeevi Yojana. Why I'm sharing this fact with everyone here is that overall the schemes, rates, tariffs have changed. Definitely there is a disparity, there are gaps, and as Alok sir and Dr. D.K. Gupta mentioned, there are areas where there are highly unviable, in fact unreasonable, I won't say unviable, unreasonable, because till the time you can't ascertain a cost to the treatment and you have a package, you can't deliver treatment. So and that's where I think medical management creates an issue. But the point I want to stress is that they have, over the last 6 years, treated so many lakhs of patients, and that data they're using to ensure that the packages for certain departments, especially surgical ones, are now attuned for a practical workup. And secondly, the kind of care they want to give and the issues that the patients are facing, they're eliminating that. So they are even thinking of coming up with an OPD plan today. The only thought here is that they are trying to improve the adoption and the fact that people should go for treatment. So it is basically expanding our pool of patients. The biggest success for this scheme, I feel, is it is increasing our patient base, because many times, because of affordability, patients would not be able to even take the treatment. And today that is changing. Even in villages, we are present. We have a corporate 100-bed hospital in a rural town, literally a rural town with a population of 1 lakh, called Balaji Soni Hospital. There, 90% of our patients are from this scheme because affordability is an issue. But the biggest point is that the patient comes with confidence now to the hospital. So if and a doctor, if he prescribes a treatment, the adoption is very high. The dropout or the bounce rate is not there. So there are many advantages to this scheme. Definitely there are challenges. We should listen to our, you can say, the customers, the patients, the insurers, the general public, and we should improve on this. There was a small study, that definitely the politics of things will come into picture, but it will give benefit to the public at large if healthcare services is made available to more people. And that's my parting thought for everyone.
Sure. I really thank you. I think you have touch based upon three major things, which of course you have shared your own experience of utilizing AI technology in MRI, and I think the follow-ups and the gap between the patient and doctors have been reduced, and you personally have witnessed the less dropouts, and good patient satisfaction. That is very interesting to know.
I just want to share, Neha ma'am, that we are doing more than 300 MRIs per day because of this technology.
Per day. I
300
mean,
per
that's
day.
really per day.
Yeah.
So,
Yeah.
I mean, really, it's a notable, seriously. So, yeah, so this is the best example which Mr. Soni has just shared, and thank you so very much. Government scheme, you have talked about the state Yojana, which has been revised every year, keeping the mind the whatever the patient's requirement, hospitals expectation, and giving them the finest experience, having the feedback into consideration, especially the consumers, and that's how the OPD has been covered by the Yojana. I think the PMJY also should actually add up such a thing, and our all problem can be resolved then from the Rajasthan government. I think that is the way ahead where we can suggest to PMJY cell to look into when we have a huge hue and cry on the packages and the clusters what they have. And I totally agree. Even just Dr. Gupta has mentioned that doctors are not ready to even take the PMJY. In my particular hospital, we have like 60 to 70% occupancy is consisting of PMJY. And I would say that DM and MCH surgeons and all such physicians are not even ready to look into the patients, just because of the cost factor, because they hardly get any money left from the package. Because what we settle is we settle our pharmacy, we settle our diagnostic, and whatever is remaining is there for hospital to eat and doctors to eat. So hardly anything is left from that cluster, and hardly any payment goes to the professional. So this is really a very big agenda. I hope this agenda across states is discussed with the PMJY cell, and some concrete solution should come. I think that is what we hope as of now. Moving to Dr. Gundavali. Sir, very good morning. We had discussed AI, we had discussed the challenges, we have discussed about the innovative ways how to reach the public. So when we talk about AIs and all that, what are your experiences when, what are the, your hospital or your group is taking some step in order to maintain the patient expectation, especially the post-COVID, be it infra, be it services, be it facilities, be it telemedicine or digital use of services. So how is your experience and how you are addressing those challenges? So can you just throw some light on it? Yeah, thank you.
Morning. Thank you for giving me this opportunity. Today, healthcare industry has totally changed. People's expectations have grown up. Once upon a time, hospital was just giving the treatment. Today, hospitality, to reduce the overall, the time spent by the patient in the hospital. They don't want to, waste their valuable time. This is what the things are happening. So some of the actions to elevate the patient experience, what we have noted is, one is elevate patient consent and personalized messages. All outreach should proactively and in personalized fashion address the key causes of friction in a patient's experience and their concerns about health and safety, such as protections, protocols in place to protect against pre-person transmission. Meet them at the front door. Health systems can address unique patient needs and ease. There is a fear till now about COVID. Many patients are not turning out to the hospitals because there is some concern among the patients. So we need to put strict protocols, and we need to create awareness. So they should feel confident. I'm coming to this hospital. They are taking all the precautionary measures. I can go to the hospital confidently and see the doctor. That kind of awareness we need to create. Enhance virtual care options. COVID-19 accelerated the need for virtual care, but many patients were looking for it before and will look for it after the pandemic. Now, health system can develop new care models that meet patient demands for easier, more accessible virtual care. optimizing the capacity to care for virtual patient and enhancing the experience of virtual care delivery. Listen through social channels, continuous listening across the social channels in a health systems, local market and nationally will enhance gathering real-time insight into patient perceptions and community sentiment. In response, healthcare organizations can quickly pivot their operations to address shifting consumer mindset and realities and measure progress along the way. And people's expectations have gone up. We need to meet the expectations. We need to exceed their expectations. Post, treatment follow, immediately calling them and asking whether they are doing well or not. At the same time, they should also feel confident. Now the hospital treatment is slowly shifting to home care services. If you see, around 30 to 40% of the treatment can be done at home care services. This is what the patients feel. Probably in the future, hospitals may have to increase the home care services. That is there. And definitely COVID-19 has created inflection point. Patient experience has always mattered, but now the stakes have escalated, and health systems that don't respond to new consumer demands are at greater risk of losing patients to competitors. As you all aware, competition is also growing up. If you don't give the proper facilities and if you don't respond to the patient's demands, then you are gone. This is the right of the position. Now it is the time to transform and grow market share by exceeding patient experience expectations. So give the home care services and reduce the waiting time and give more what they're expecting. Regular follow-up, since the data is available with us, close follow-up is very, very important. They should feel confident about the doctors and hospitals. These are my views.
Yeah. Dr. Bundawali, I would just conclude. Thank you, first of all, for showing us one example. While I was listening to you, one example came to my mind. As we are moving on, I think, look at around all the apps what we use on day-to-day function. One is our Zomato or Swiggy for our small, home core needs. And I have noticed that, when you order a pizza from the Zomato, immediately after deliver, that is a notification come that how did you like it? And when you click on that, there are a lot of parameters from the delivery boy to that quality of the food or whether the food was hot or not, and a lot of other factors which they have addressed. And that is so interesting. I mean, unlike healthcare, you had talked about the home healthcare, you had talked about all, patient satisfaction, expectation. I think these expectations are still there in the mind of patient. Though it is related to health, we often forget to ask them that how are they doing post-discharge? How are they doing after having the diagnostic test done in the hospital or elsewhere? We just take the money, provide the service and forget. So this is our whole customer base, and we are not able to maintain that, particular with the AI based, I would say, or any kind of feedback system which hospital and healthcare organization can prepare and launch. So I think healthcare is actually lagging behind in adopting the technology, I would say, and lagging more behind in changing their perception. I think all of us, I request all the seniors are here. They can, take this up, and I think we can change the healthcare, because the healthcare is a services like hospitality, as doctor just mentioned, that when we go to the hotel, I think all your front office staff to the, whenever your stay is done, everyone will have the smile on their face. They'll wish you, they'll ask you, how are you today, kind of thing. But when you come to the hospital, our nurses and staff often forget to smile, isn't it? I mean, all of us who are working in the hospital, because they are so much into that work and they forget the soft skill, I would say, rather than we do not smile, we do not ask patient that how are they doing today. Even many of the times a doctor doesn't know the patient name and patient doesn't know the doctor's name. They just talk, communicate, provide the treatment and gone. So, that personal touch, I think you have showed that personalized care, personalized approach should be built up to exceed the patient expectation and to maintain our customer database. I think that is what I have gathered from your talk. Thank you so much for showing this, doing this approach of the healthcare. Moving on to Mr. Adarsh from Ovam Hospital. Sir, very good morning to you.
Good morning, Mrs. Lal.
Thank you. Sir, we have talked a lot. You were there and patiently listening all our discussion and interaction. Considering your kind of organization where women, pediatrics, the children are taken care of. Recently, we have celebrated Women's Day across India. And this time I have seen first time that Women's Day is actually being celebrated at all the organization very high pace. I think gradually that particular movement is building up. So, how are your thoughts when we talk about the healthcare infrastructure post-COVID? What should be the ideal infrastructure, let's say, for men, women, and the children and neonates, which is, kind of need of an hour. Woman needs kind of a services and facilities different. Children would need different kind of, facilities. So coming from that background, we would like to know about, your experiences and what are your thoughts?
So I'll talk about women and children as main.
Yeah.
India used to have a lot of high maternity mortality rate, where a lot of women used to die at childbirth. But government has taken a lot of steps. If you see, maternal mortality is decreasing at the fastest rate in India as compared to the global average. Almost 75% reduction is there year on year as compared to the global average of 40s. So we are doing fantastically well there. Coming to deaths at newborns. So in 1990s, 50 babies used to die for every 1,000. After 30 years, we have come to 20 babies per 1,000. So where are we in developed countries? Developed countries, 5 babies die for every 1,000. Again, government to improve this started putting special care baby units where they realized for every 10 births, there will be 1 or 2 high-risk babies. They need some sort of a neonatal ICU.
Yeah.
But they don't have that much manpower. So purely nurse-led units. See, corporate hospitals, they are doing well. Urban areas, rural areas, wherever there is a big hospital in a big town, they are doing well. Medical college attached. But there are many talukas where the special care baby unit has 6 to 8 babies, but nurse-led. They can't have a neonatologist in every taluk. Government is only allowing medical colleges to adopt them, not allowing private sector. Look at the irony. They want to reduce neonatal deaths. All the corporate hospitals, you go, Neha, Delhi, Mumbai, Bangalore, we are only running our NICUs at 50% occupancy. Every person here knows if they have a 10-bedded ICU, they have 5 patients. There is easily 5 empty beds, but they are not allowing corporate hospitals to take. They feel that corporate hospitals will take away those babies and charge them and whatever. And somebody had raised the insurance point. Even if a corporate hospital takes it, only 2,000 or something they are giving for a baby per day, which is practically impossible. Almost any NICU, 10 to 15,000 per day will be the cost. That also should go up. But what I'm saying is, if we were allowed to adopt this very with the promise that if at all a baby requires a transport, it will go to that particular hospital because those hospital doctors are taking care of the other babies. Otherwise, what's the scenario now? If some baby can't be managed there, it goes into an ambulance. That whims and fancy of that baby's birth, alive or death depends on that ambulance driver. He can go to any nursing home, any hospital. That baby can die on the way. There is no regulation on this. You just need to call 108. Somebody will come and pick up the baby. Then the baby and the baby's parents are on their own. If they get a government hospital or a medical college, NICU slot, good for them. If not, they're waiting hours together in front of somewhere where either the baby dies or it goes into somebody. This can easily be regulated to such a beautiful extent, such that these deaths easily can come down from 20 to 10. We have that infrastructure.
Sure.
Third was that, so tying up with corporates, slightly increasing that Ayushman Bharat rates to at least make the NICUs in private viable if they carry these babies. Third was that point, AI. AI, if they adopt, beautiful. I can show you systems now. The AI, if you're going to connect to the ventilator, the baby's vitals, the baby's blood tests, some can automatically take, some could be that you have to manually integrate. Seeing the heart rate, respiratory rate, BP, saturation, glucose, blood parameters that AI is throwing up to you, there is a 10% chance of this baby collapsing in the next 6 to 12 hours. There is an 80% chance that this baby will collapse. The AI is
okay.
You don't have to do anything. This is not like the doctor has to come after the collapse and said, look, हम बहुत कोशिश किए, लेकिन हम कामयाब नहीं हुए, I'm sorry. No, AI is telling you, in this condition, this baby is collapsing in 6 hours.
Yes.
Make that more that time. Poor nurses, they don't know. But the beauty is that machine is calculating everything. It is seeing the heart rate, it is seeing the vitals. So that is the time you shift it. See, you, me, everybody want to reduce this 20 per 1,000 live birth mortality to 5. 5 is where developed countries like England, America, or Japan has reached 4. And 20 to 10, little tying up the government neonatal SNCUs and the corporate, easily they can come off to 10. Of course, with that CGHS rates, with that use of AI, many private hospitals can have this AI. So these are my thoughts in improving or reducing the neonatal mortality. And that is what I keenly care about.
Thanks, sir. I think first important point which you have just shared, and that is a very commendable thing, that maternity rate has actually in India is the lowest. And I think the contribution made by the corporate hospital to So the contribution which has been done by the private sector in this particular achievement, that is commendable. And interesting topic you have just shared about the right use of AI, where you have a shortage of nurses. I would say the skilled and talented nurses to handle the neonates, which is there in a country like us. To address that particular gap, if we use the artificial intelligence, which is throwing up you with the talented and all the balanced data for clinicians to take a decision, that is something very much marvelous. And I think what I look forward in this next decade, the healthcare is going to be AI. I mean, the main agenda to how to use the AI and what are the new concepts can be built and can be utilized for not only the satisfaction, I would say the better treatment approach, better outcome, the clinical outcome, as doctor has just mentioned. I think that is going to, bring in significant differences in the patient life, all as a community as a whole. So yes, the AI is the word which can come up in next decade. So that is what we have concluded. So yes, we are mostly touch based upon all the important points, whether it's a healthcare IT infrastructure, physical infrastructure, reaching out to the rural, the various challenges in the government scheme, be it PMJY. We have discussed on various state government scheme and how the state government is looking into the schemes and government clusters and all that. So putting together, I think I'll just quickly see whether we have any questions coming up from the audience. No, I think what we can conclude is I would just like to request all the eminent speakers here. You can just share the one-line message for Mr. Chandan and ArdorComm Media to take it forward out is this interaction. So we'll start with Dr. Roy. He's available. Dr. Gupta. I request ArdorComm to just quickly connect with them because I think they are occupied somewhere. Meanwhile, I'll just ask Mr. Namit Soni just to share your one-line message for the group.
I think after hearing such a powerful talk, especially from Adarsh sir, how passionate he is about neonatal care, I just want to share a message for everybody that we should focus on increasing our reach towards the patients, going more to rural to provide healthcare services. I mean, the better and the more we can reach the patients. And I think technology, government support, and our will as a private sector would really take us closer to that goal there. And I think we should all work towards that. That's my only thought. If we get more, we can cover more healthy population. We can have a healthier population. I think we can really
Thank you. Got this.
So from my side,
Yeah, from Mr. Adarsh, yes.
Sir, tie up with the government special care baby units and the corporate hospitals in the nearest 10-20 kilometers range, such that more and more babies can be easily managed and saved.
Thank you. Thank you, sir. Dr. Gupta, please.
Yeah, I think spending a lot on GDP on the healthcare part, basically, we should increase at least 2.5 to 5% within 2 to 3 years only, and after that, cumulative expenditure should be increased on this healthcare industry and healthcare sector. Second, insurance penetration should be increased, being it government or private. Rates should be revised for CGHS and Ayushman, especially for packages, and also strengthening preventive and primary healthcare services at rural area and tier 3 and tier 2 cities. And that is, I think, this part.
Sure, sir. Very clearly you said, and I think increasing GDP and budget, healthcare budget would, I think, able to provide all the solutions for all of our expectation, be it a rural healthcare, be it the capex or infrastructure, or we talk about the AI tools. I think, yes, the market has to go up. Dr. Vrundavali, please.
Now change is inevitable. We have to accept the change, adopt a new technology, and accept it. We doctors should improve our overall understanding the technology. Still, many doctors are not accepting the technology. So some discussion in the discussion, they don't like it, but we have to accept it. The future is artificial intelligence.
Yeah.
Probably in the future, we don't know what is the role of the doctors and healthcare workers. Artificial intelligence may take over most of the things what we are
functions,
today. We have to accept the change, and at the same time, public-private partnership is very, very important to improve the rural services. So government should provide basic infrastructure. They should give tax exemptions if suppose hospitals are coming up in the rural areas. So this is my suggestion.
Very rightly said, sir. When we talk about the mindset, yes, we do face a lot of difficulties because the senior doctors have their own mindset to treat the patient, and that is how the resistance is built up when we even simply talk about implementation of EMR in the hospital. So when they don't want to be like to operate the computer or pad or mobile app, I would say, and they have their own approach to deal with that. So that is how the things are. But I'm sure that in a coming time, people will have to embrace these change. People will have to adapt and accept the way COVID has taught us a lot of things. So I think looking forward to that. With that, we end this particular session. If any question from anybody, they can just raise from the audience, or otherwise I'll just hand over to Mr. Chandan. Thank you so much.
So yeah, as of now, I cannot see any question, but definitely what wonderful output and outcome has come from this particular session. It was just a small topic, right? Healthcare infrastructure, and see when the expertise meet and when they share their experiences and few case studies, the outcome of an event or a topic becomes something else. So thank you, Dr. G.K. Gupta ji, for joining us over here. Dr. Alok Roy, Mr. Namit Soni, Dr. Vrundavali, Mr. Adarsh, and Nehalal, a wonderful moderation. Right justice to this panel, I must say, you have done that, because they must have a good expertise and knowledge, but putting right questions and getting the right content from them is a task of a moderator. Starting on time and ending on time is an equal discipline which we need to understand in these virtual forums. Because once the mic is given, we try to explore and say everything which we have experienced, but in limited time, right words, and so that it should connect with the audience as well. What we are saying is actually right. I was impressed about the passion, with what passion Namit was saying, that the new MRI machine, which he has just implemented in his hospital, and the way and the fruitful result with that, which we were expecting before purchasing that machine, and the result the satisfaction level is altogether different. Because when you invest in something, it's not only a money, it's about your time, it's about your, the energy, and in fact, the training which you give to the person who is operating that particular system. So if it becomes a user friendly, with this, a quick question from Namit, I would ask you, अगर किसी को इस तरह का कोई टेक्नोलॉजी परचेज करना है, आप ही परचेज करना है, so what may be 2-3 factors or points he should keep in mind before going for that health tech purchase? Any comment on it?
So the biggest thing of any health tech purchase is what do we want to achieve, and we can have a razor focus with whatever technology. Today, I mean, to just share a small example, there is a app available for security guards. You can have an app available where all your security guard can be on that. I know most of the people must have put their car and their ambulances on, GPS tracking and all that.
Yeah,
but today, imagine your security person is also on an app which is dedicated for security. And every round he takes, he has to do the checklist and put the photo there. You don't need to create your own system. You don't need to create your own Google Sheets and all. You just need to buy that app on subscription basis. So, that is where technology, you need to know what you need and search for it. And today you can get it in the market. There are so many startups and so many people already investing in that you don't need to reinvent the wheel anymore.
Okay, great.
In that case, Mr. Chandan, you'll have to throw the physical, new normal conference where all the AI solutions is available for us to review and experiment. I mean,
absolutely. Neha, in fact, what would be your answer to it? अगर किसी को इस तरह का technology purchase करना है अपने hospital में, so what maybe 1 or 2 points one should keep in mind?
Actually, as Mr. Soni has just mentioned, I would rather, if we talk about the patient per se or making a difference in the people life, I would rather seek the feedback of the end user. So as he rightly pointed out, the security guard. So what I do when I head operations here, if I have to bring in any change, let's say any issue or system is interrupting, I always discussed at the guy sitting on the counter at the reception, because they are the user and they know better than us. If you ask the staff nurse, how is this patient, she will give you exact feedback. Khana acha tha ya nahi tha? Patient was unhappy with the doctor. Patient has this difficulty in the washroom. Patient has this difficulty in the linen. So all putting together, I think interacting with the user will give you the best idea that which are the exact issues and which are the app or startup available to address those issues. So I think, and then you can have the marriage of these two things. I think then you can make a difference rather than having startup or any other app just for the sake of it and making it no value in your system. So first format, you have to do your gap analysis, having incorporated all your users. When I say users, you involve the patient itself. When we are talking about the stakeholders, all the stakeholders are involved from doctor to the patient, and then come out with a solution. This is our exact requirement. This is our exact need, and which kind of solution is then available in the market to explore. I think if that approach is taken care of, we can only make a difference. I hope our speakers also would agree to that when it comes to the practicality world.
Correct. In fact, I was also very much, inclined and attached to what Dr. Vrundavali also said, that in a very easy and a very, straight away language, he said that ki user demand ko address karna bahut zaruri hai. You need to address, because or else you'll be losing that particular customer. Jo pata nahi, maybe saalon se aapke paas mein aata hoga, but one new entrant in the market, ek naya infrastructure, acha, if he gives a good service to you, in terms of after sale service, agar usko naye hospital se ya clinic se acha mil gaya, that entire energy of engaging with that customer of 10 years long will go in seconds.
Sure.
So uske liye any app, Dr. Vrundavali ji, which you have implemented in your hospital, or what advice will be for the other players who are listening you?
Yes, sir. We are working on one application where the patient's data, using the patient's data, patient will be like, I am aware about that patient and what was the previous diagnosis, and that the same information will be received by the doctors. And at the same time, when the patient comes in front of the doctor, he is aware about the patient. And at the same time, patients, once the treatment is taken, it is followed up regularly using the artificial intelligence. We are working on that. It takes some more time. So for the patient satisfaction, it is very important. Suppose we go to the marriage hall, we expect someone talking to us, receiving us, taking onto the stage. Whether you like food or not, that is different. If someone is not, talking to you, then you will definitely don't like that event. At the same like that, today what has happened? There are some hospitals who are filled with the patients. There are some hospitals no patients. What is the reason gap? We need to understand. So customer satisfaction, if you don't handle that, then definitely that healthcare system fail miserably. So we have to adapt the change, and using the technology, we need to continuously follow the patient. Patient should feel I am taken care by real hospital. They
Right.
take care about me. My health is in safer hands. So that kind of satisfaction they should use.
Right. Okay. So I've asked everybody, Dr. Gupta ji, your remark to it.
I think patient experience is the most important thing, as already told by the speakers and other panelists. If we map patient experience from where they are starting, means from lead generation, if they go on the website, if they come to our parking area, if they come to your entrance, all five senses should be measured, like smell, taste, hearing, vision of that. And the assistant should be everywhere from whenever patient walked in to the end of the patient cycles. If patient is coming in the OPD, like if from the parking area to guard, reception, even hand holding at the billing area, from billing to counter, like vital charting to doctor, there should not be gap. He should not feel alone. And after that, whenever he comes out, he will be having some radiological test, pharmacy, or cross consultation, surgery. If somebody walks in and help you out, definitely it will improve the patient experience, and definitely it will improve your revenue also. There will not be leakage out. Leakage will be minimized. And after that, you can take out the testimonials, their feedbacks also. You can improve your operations, your system and processes also. I think patient should be the focus, and patient should be the center point. Everything should be patient centric in the hospital. And if we make happy or make their experience wow or super wow, definitely you can grow anywhere, whatever you want.
Great. Thank you so much. Nehaji, there is one question in the chat box. Would you like to?
Yeah, let me
that?
just check. Yes, there is a question coming from one of the listener. That is, how about the efficiency of the AI systems incorporated? I'll hand over this question to Mr. Soni.
So it's a very good question. I mean, the fact is that I'll go a little technical here. That when you implement something in IT or you implement some new technology, there's a thing called alpha testing, beta testing, and going live. I mean, the place where people actually miss out is they rush the product or rush the service to the end user or the patient in our case, and that's where I think things go for a toss. I feel that we should do a rigorous testing or an implementation audit for what service or what AI technology we are implementing. And if we can do that, and if we can give a nice experience, then the product or efficiency of that AI system will never be questioned. It's just the fact that through the whole process of implementation, we keep rushing the project. So that is something we should be a little careful, or we should be a little wary about that, and we should take our time to get the thing to the end user, because the patient cannot suffer. We can't test it on a patient, and in our case, it's their life at stake here.
Yeah, I think the best answer you have provided. I think the users the listener must have got the right the point out of your report. So yeah, Mr. Anand.
Yes, so with this now we conclude to one of the very interesting and the first panel session of the day. I think this insight has given a way forward how we can progress with the other panel speakers and the topics. Thank you so much for joining. So with this now, let us do one honors. We would like to regard and we'd like to honor you for your special contribution in the field of healthcare industry by felicitating you with a certificate from ArdorComm Media.
Thank you so much.
small token of appreciation goes to Dr. D.K. Gupta, the chairman and MD of Felix Hospital. So it's just a motivation. Keep doing the things which you are doing so that it keeps
Thank you so much.
motivating the healthcare community. Thank you, sir, for joining. Next. It goes to Dr. Alok Roy. Is he here? Okay, he must have left. Thank you, sir. Token of appreciation goes to Namit Soni, one of a dynamic CEO representing Soni Hospitals. Congratulations, sir.
Thank you, sir.
Next. A certificate of recognition to Dr. Vundavali Suriraju, the MD of Regal Hospital. Thank you, sir.
Thank you, Ramesh.
Mr. Adarsh Somashekhar. And lastly, to Ms. Nihalal, the Senior GM Operations and HR from, you are handling two divisions. One is the college, another part is hospital, combined with the research center. Commendable job, Nehaji, and right justice you have given to this panel session. Thank you so much for joining.
Thank you. Thank you. Thank you very much.
So with this, we move ahead with the panel 2 session. May I please invite my colleague Itisha. I was just waiting for the industry presentation to happen from Kenoff Solutions, but I guess he's traveling. He might be joining sometime, so maybe we'll be including him in any between the sessions. But with this, we progress towards the panel 2 of this session. Itisha, may I invite you to introduce the session?
Thank you, sir. Thank you so much. It was great session, and listening to you all give us an insight about how the industry actually works. What are the practical scenarios? So let's move toward the session 2 of the day. So let me invite Ms. Ekta Modi, COO, Parul Sevashram Hospital, Dr. Rupali Basu, Managing Director and CEO, Woodland Multi-Speciality Hospital Limited, Dr. R.V. Karanjekar, CEO, Kiran Multi-Super Speciality Hospital, Mr. Yatesh Wahal, Executive Director, Niyati Healthcare and Research, New Delhi, Dr. Venkat Ramana Sudigali, Director and CEO of Excel Hospitals, Hyderabad, Telangana, Mr. Devanand Keti, Regional CEO, Esther DM Healthcare, Hyderabad, and Mr. Devanand is also the moderator of the session. So we welcome you all. It's over to you, Mr. Devanand.
Hi, thank you. Sure. Hope I am audible.
Yes, sir.
Yeah, thank you so much. Thank you so much, ArdorComm and Mr. Chandan and the team for inviting all of us. I'm really excited today to be here among all of you for two reasons. One, it's a very fantastic panel that I have to moderate. Very distinguished and accomplished panelists that we have today who will be speaking on a very important subject, which is the rural-urban healthcare divide. So that's a very interesting subject. Usually you don't hear this subject being discussed much in any of the panels. So I'm really excited to be here. And are you planning to give an introduction of the other panelists, and then you want to start? How is it going to be? Yeah, Itisha. Hello. I think Chandan, you are on mute.
Sir, you can start the session and let the panelists join in between.
Okay. So I'll start myself. So I'll just introduce myself, and then I'll start with the first panelist so that they can also tell something about themselves, and then we can go with the flow. So I'm Devanand. I'm the regional CEO of Aster DM Healthcare, covering the Andhra Telangana cluster. I handle 5 hospitals in this cluster. So I'm with Astra for the last 13 years. I was in Kerala and then moved to Hyderabad subsequently in 2019. So it gives me extremely, I mean, it's a happy occasion for me to moderate the panel for two reasons I mentioned earlier. So without much delay, because we have a time constraint also here. So I go to the first panelist, who's the chief operating officer of the hospital, Parul Sevashram Hospital, Ms. Ekta Modi. So who is going to probably give us her insights on the first thing, which is the first and foremost thing to start the discussion, which is what, according to you, Ms. Ekta, is there a health divide? First of all, that's what we want to know, right? From before we start into this very interesting topic. So, is there a healthcare divide among the rural-urban class, and what are the factors do you think are creating this real healthcare divide among the urban and rural class?
Thank you, Mr. Good afternoon to everyone, or this senior panelists and actors. So, telling about myself, I represent Parul Sevashram Hospital, which is a teaching hospital for Bharat Institute of Medical Sciences and Research. We are a teaching hospital for undergraduates and postgraduates now. So, yes, we are.
Sorry to interrupt. Please be a little clear or bring your mic to your near mouth so that we can listen properly. Sorry.
Sorry. Now it's better. Hello.
Yeah, it's better. We can hear properly.
Better. I think your microphone, if it is closer to your mouth, it'll be more.
Yeah.
Thank you.
I think I'll speak a little. So we are a teaching hospital for undergraduates and postgraduates, and we are presently in a rural area of Kaduna, that is Baghova. So yes, the very important thing which Mr. Dave brought in was factors impacting the urban-rural healthcare divide. So yes, it's a divide because there are a lot of factors which influence and affect this, like the awareness, the health awareness, which is very important when we speak about the divide. So the rural people, we used to feel that they are not that much aware about the health benefits they should seek or health schemes they should have. But thankfully, COVID has brought up so much awareness, even in the rural sector, that now they are also aware, they are also informed. So the gap is bridging in some of the factors. But the awareness still needs to be more in the rural areas. The level of education is also an important factor which is impacting the urban-rural healthcare facilities. The economic status of the families or the patients coming from rural areas impact the health benefits. And most importantly, the availability of healthcare. So if the availability of healthcare is not like it's very rare, then they are not focused to the needs they have, or if we say the preventive healthcare aspect, which we find more in the more in the urban areas, it's not that prominent in the rural areas. They visit the hospital only if it's a dire emergency or if they need to. Otherwise, when we talk about the urban sector, we all know that the preventive health checkup is like booming. But now, even in rural areas, we are going in their cities. So the remote areas are now there very well with the available infrastructure, which I'll be talking in my next version. So yes, the outreach needs to be strengthened, and like there is less use of the certain health informatics which they have. Then there is decreased preventive health checkup, which we spoke about. Health literacy, which we are planning to a lot of sessions. We are engaging the ASHA workers and everyone who are they are the key people for the rural areas whom they look up for their health benefits. They reach out to the ASHA worker only if they have any health benefits. So educating the health are following in rural areas. We are strengthening the structural barriers, like there is a shortage of super specialist doctors in a certain rural area. So we are now developing certain e-kiosks, which act as a boon to the rural areas. So I think even financing the health sector is a long-standing challenge because the rural areas are not that economically. So I think we need to use all the available channels which we have to close this rural and urban gap and promote best practices like using the holistic healthcare model, which is now a need of the hour to reach the rural population.
Thank you so much, Ms. Ekta. Very, very elaborate, and so I could understand the awareness, the accessibility, and also the shortage of manpower. These are the few things that really came up from your point. So there, you are seeing that yes, of course, there is a divide among the urban and rural healthcare. So and there are ways in which that can be addressed also. But with the new budget, recently unveiled by our health finance minister, we know that there is a huge impact that's going to happen on the e-health or the digital health that we see in India. Especially, there is a targeted focus towards implementing those digital things across India, which will cover the rural side also. So we have the next panelist. I would like to get his insights on this particular aspect, where India is also focusing on the digital health across the country. So that will definitely focus on the rural areas also. So how do you think, Dr. Karan Jekar, who is our next panelist, who is the CEO of Kiran Multi-Speciality Hospital, who is a veteran in healthcare. So how do you think, Dr. Karan Jekar, how can we solve this lack of e-health services in rural India, where India is a country where we are looking towards a digital health adoption?
Taking their parameters or having a face-to-face conversation. So this process at the end of the patient has to evolve. And at the other end, even from a clinician's perspective, moving on and transitioning to a totally EMR-based environment is something that, again, the present constraint of the pandemic assisted us, but still the senior doctors, those, there are exceptions everywhere, but you can't expect them to change overnight. So whilst the fresh breed, the fresh crop is adapting to it and people on the floor are the ones who are getting into EMR, some of the senior doctors are still not very, very comfortable with the EMR part. Having said so, the core question that was posed to me in terms of capital funding and how that is an influencer in terms of the adaptation, see, capital plays a very important role. And one of the reasons the urban-rural healthcare divide has also been around is because healthcare intrinsically is a very, very capitally intensive industry. And IT, unfortunately, till a few years ago, never played a very important part. And it was always supposed to be a cost center. Now, with time, it has become a strategic cost center wherein one is starting to see that if you were to digitize records, in addition to patient convenience and access, what that is also resulting into is additional revenue. E-pharmacy, if you are able to map your EMR into pharmacy, into diagnostic, if you know what your doctor has prescribed, the administrator or the front office at the end of the day or the department at the end of the day is able to check its conversions. See, till everything is linked with revenue, it really doesn't work out. So that somewhere has helped as administrators also not to get our bosses, the directors and the funders or the trustees to see value and introduce this. Having said so, again, because the number of adapters are still limited in the market, the cost of introducing this technology, the cost of introducing this hardware is huge. And for a small rural-based setup or a non-metro-based setup or a metro-based setup with just a single unit and not a chain, they may find a capital allocation to be slightly difficult. And therefore, this problem has to be assessed in totality. If you were to today again spur entrepreneurship in this, and there are solutions that have come about, and one of them being that the market knowing that money cannot be brought in overnight, and even if you were to bring in soft capital, today rate of interest is still not below 8-9% for an average borrower. For someone with a A+ rating, maybe it will be about 6.5-7%. But the repayment starts, there's not enough moratorium. Unlike some of the, for that matter, even Bangkok per se, or Thailand, wherein, you have repayment periods, or Indonesia, where you have repayment tenures going up to 20-25 years. Because healthcare, and this is one of the need that all healthcare players have stressed to the Honorable FM also, wherein we are saying give this infrastructure status and give them a longer term funding tenure, so anywhere between 15 years to 25 years, so that there is enough cushion available for healthcare players to recoup the investment made. Now, one of the ways technologically based Indian entrepreneurs have started to solve the problem of technology adaptation is they have brought in a model of pay-per-use. Instead of and somewhere using the power of cloud computing and cloud servers. So, see, there were two constraints. One is you need to have heavy servers for backing up all your files and having a redundancy in your network. The second bit was your network issue. Fortunately, with the likes of Jio coming in and 4G and 5G being made available, this problem has been addressed, as Rupali was also mentioning, Dr. Basu, that, now with smartphones coming in, it's getting addressed, but somewhere Indian entrepreneurs had even sorted this out, wherein in India, the sort of products that offer these services are more built on a 2G based platform as opposed to a 4G, 5G, so that even where in areas, remote areas where data proves to be a challenge, there is still a probability, albeit with a longer delay, of sharing the data packets across. So with cloud computing and hosting your servers on the cloud, somewhere like a Google or a Amazon-based server farm, you are able to pay this and on an OPEX-based model and not a CAPEX model. Likewise, you have players who've now come in and they are charging on EMR on a per patient basis or a per visit basis, as opposed to just selling the entire show in one go and blocking a huge amount of CAPEX and then going in for an EMC, CMC. So, wherever there is a constraint, history has it that, constraint leads to inventions, and Indians, all of us, are far, far ahead when it comes to the road of invention. AI, for instance, a lot of local players, tele-reporting players, and even some of us at the corporate hospitals, the teams had standardized protocols wherein just after a scan, basis the pattern that had developed in the lungs, one was able to tell whether there was a COVID case or a non-COVID case, and one really didn't have to wait for the reporting to happen. So, AI and technology definitely is here to help. Cost obviously has been a concern, but with, the metros really reaching a sort of a saturation, and local partners coming up, you have all major chains which have, at least for now, if not really gone into the rural areas, they've started opening centers at least in state capitals. So the presence has started, because this movement of going to the metro for treatment is stopping. And the core problem, again, still today that stays there is that given the very size of the country, which in itself is the opportunity, we do not have the number of healthcare practitioners to cater to that entire demand. And thus, using technology, we can get in these skill sets that are available with the metro-based setups, maybe within the corporate setups, available to the last chain, available within that corporate center.
Yes, Mr. Yatish, yes, thank you. Thank you so much for that. I think
Thanks,
the paper use, the OPEX model of technology coming in can really help us in getting it implemented across rural India, where the capex or the capital investment can significantly come down. So that's a very, very valid point. I think a lot of people have already started experimenting on that. That takes me to the next question to Dr. Venkat, who's our next panelist, whom I know that he has started teleradiology at a much earlier stage than all of us started doing at our hospital. So Dr. Venkat, I think you are the one who probably were the front runners of the teleradiology mode. I know that. So how do you think, can the information access play a vital role in bridging the gap between the urban and rural divide? You have been a proponent of the whole telehealth mode. Over to you.
Thank you. Thank you, Mr. Devanand. and thank you, ArdorComm, Mr. Chandan, and Ekta, and the rest of the team for inviting me. Very interesting discussion so far. I've learned a lot already from the eminent panel members. So thank you, Mr. Dev. I don't call myself as any pioneer in teleradiology because probably it has been there since much longer time than when I started in India, because I was the one who actually started my radiology career with the films, and I actually saw how the transition happened from the films to the digital radiology settings. So, it has been quite significant journey for me personally as well as professionally. But saying that, things have certainly taken a very, very drastic turn for the better in general regarding healthcare technology, but specifically to teleradiology, telepathology, and to a certain extent, telemedicine as well. So coming to my field of teleradiology, so we in our hospital report for patients across the world, especially UK, Ireland, and Australia. And I'm one of the clinical leads for a big organizations in the UK. And the technology which is currently available, which permits us to report a patient who is coming in acutely unwell in a remote hospital somewhere in Europe, and sending the scans 4,000 miles across the ocean to India, getting reported and sending back, and clinicians taking an action, all happens within 4 or 5 minutes for patients like stroke, for example. So just amazing if you can imagine how this has been carrying on since the last few years. And the added benefits of AI, which is coming over since the last 1 or 2 years, which has been propelled by COVID times, has been even, more made this space very interesting and very fascinating. And future can be very, very bright based on what I'm seeing at the moment. So what we currently do is we have an AI algorithm which triages, just like a human triaging a patient who is very unwell versus patient being very well. So it triages and highlights to us saying that this patient has got something very abnormal on their scan. So we need to look at those scans first, because a few minutes may mean a life and death matter for those patients. So once the triaging happens, it comes to us and then we get to see the reports. And I have an extension number which I can quickly call the clinicians across Europe and then get the report onto them. And we literally saw several patients being treated this way, several patients who would otherwise have a very difficult time to survive or have long-term consequences, but just getting better with all this technology in place. So in one word, it's absolutely brilliant. But let us go to the opposite side and speak from the Indian perspective. Whether this technology benefits, if so, benefits what kind of population? Are we talking about benefiting only the rich, higher class where the affordability is higher? Because certainly it adds to the cost of the healthcare system. Technology is not cheap, so we really have to take it appropriately. So not add each and every technology to what we consider as very good, but it's all a balance that we have to maintain, and to see whether the money that we pump in, the investment that we made, gives us a better quality of clinical care to the patient, B, improves patient safety, and also ultimately reduces the cost to the patient or to the insurer. I think if we don't keep all these three things as top priorities, especially the long run cost of the healthcare system, secondary to use of technology, I think things won't be so sustainable. And so that has to be always kept in mind. Thank you very much once again. So, yeah.
Thank you, Dr. Venkat. I think, it's look interesting, the AI algorithm that you're mentioning about triaging. We'll come back to you later with a few more queries on that. So now you have opened up a specific thing called affordability in terms of the, urban-rural healthcare divide. Affordability is a major issue, especially when the rural mass is considered. So That takes me to the next question, which I want to again go back to Ms. Ekta. See, the rural, we know that urban, the kind of healthcare that we see, the payer mix that we see in the urban healthcare is moving more towards the insured class. While you see a lot of gap in the rural areas still to adopt to that insurance, even though the Ayushman Bharat and the public health has come in to support them. But in terms of the private insurance, it's still picking up very slow. So what do you think? How can the e-health services reach this uninsured rural class? How do you think that can be achieved?
Yeah, so that is a very interesting topic when we talk. And I think I remember the saying which says that we should not cut down jungles, but the need is to irrigate the deserts. So I think this is a very untouched area wherein we never thought that how fast the internet services or the mobile data services can reach rural areas, and even rural people can get benefit on that. So even we have a question from audience also on how the small clinics can collaborate with big hospitals to serve in the specialities or super specialities which are not available in the rural areas. So nowadays many startups are coming up, and even we have collaborated with one of the startup who has developed a kiosk which we have placed in the rural clinic. The doctors who practice in the rural areas, and for any super specialist consultation, they don't have to turn here, because many times it happens that they have lost two followers. If a general physician advises for any super specialist consultation, then it's not a surety whether the patient will come over to the hospital, get the consultation, or for the illness itself. So I think this by this kiosk, which is like more over a teleconsultation. So the consultation is done, medicines are prescribed, they can get a prescription there, and even a few blood tests and like common blood, like blood sugar and even BP measurement and everything is also done. So the need of the hour is to reach them. So reaching the rural population is very important, and we need to reinforce them, like usually rural people, people staying in the rural areas, they don't visit the hospital saying they lost the mandates of their working. So minimizing the ALOS, the average length of stay in which the patient gets admitted, reinforcing them the need of safety and everything, which is very important to cater in even Ayushman Bharat scheme. So a lot of this Ayushman Bharat schemes, people get admitted here, but due to the ALOS, they are very, very, they abscond, they don't stay, they don't follow the doctor's advice. I've been practicing in a hospital which is in the rural area, so I can relate to these very well. We have a lot of patient abscond, and the reason simply says that we cannot lose our manner of earning. So this is what we can pitch in and how best we can get this. Of course, reinforcing the geriatric care and the Anganwadis for nutrition for pediatric population is also a very important aspect in which we should look up for when we're talking about the urban rural divide. So I think we should improve the emphasis on the surveillance. We should have the data by which we can come to and where exactly we can intervene and help the rural areas to grow up and use the urban sector too.
Thank you, Ms. Ekta. Thank you so much for that wonderful insight. So, using the public system also to support you in adopting to the technology or, or going to the masses will be a brilliant idea. Probably Ayushman Bharat will make that revolution coming in, like Jio brought the mobile revolution to India. So the government will be the starter here, and then probably private also will take off in rural. This is what I also expect to happen very soon. So I'll take the next question to Dr. Rupali. I actually handle the Andhra Telangana cluster for Aster. So Andhra was a new market to me. Recently, I was covering a portion of Andhra where I was looking at different opportunities of getting connected to the rural Andhra. Andhra has still had a lot of villages which still doesn't have that kind of an access to healthcare. So when we were thinking of an outreach center with a telemedicine model, the major thing the team was telling me that there is a huge behavioral change in consumers that's required. People still, I think Dr. Karan Jekar mentioned about it, the human touch is missing when telehealth is considered. They still feel that a doctor has to be present physically to give the care. So how can this consumer behavior could be influenced, towards the digital adoption? It's very tough, I know, but you have been working with that, so we expect some good insights from your side. Yeah.
Thanks, Dev, for the question. Yes, as you said, behavioral changes are the most difficult part, because you are actually going inside the mindset of each individual, and we all are, we think differently. Everybody is different. So we have our own thought processes. And when you want to change those thought processes, any change, and especially in the mindset changes, takes time. And it takes a lot of factors. So I think the low-hanging fruits, what we can do as healthcare, healthcare professionals at this point of time, is that COVID has taught us a lot. It has actually pushed us to the technology front a lot. Each of our phones, actually, the moment you take a call, that it is telling you that do this. From the government also, they were giving a SMS message, you are getting a caller tune. So the process has already started. What we need to do is should not slow down on that process. We should not, we should take the advantages of what has come in, what the new things have brought in for us to connect to people. What are the tools that I have? What are the messages that I can do? How we can do it? What are the ways we can? And we have to, kind of be at work and execute those at this moment. We should not miss out any time. That's one particular point. Then the other part is that how you are going to do the communication to the person. What are the tools that you have? You have primarily, the newspapers are gone from our lives now. It's nobody reads lately. Even now, the newspapers do come into our homes too. We are very traditional newspaper readers, but it is the value of a newspaper is going down. We have a phone in our hand, and we have the TVs, or maybe probably the laptops and the computers for some people. In the rural areas, I think TV is a tool which we have, a connect, and also the mobile phone. So we have to use maximally what we can. We have to do in SMS format. We have to do caller tune format. If I look at the phone, because if it's a smartphone, then there can be, all the social medias are available there. The apps can be downloaded. You can create new things, and continuous communication in the regional vernacular languages, looking into the, people's mindset, that what will work for them. That's I think the quality of communication is the next bit. What we have, the time is right. What we have in our hands is only the TVs and the phones. And TVs are very expensive when you would like to communicate, advertise, or say. So we have to use government in this a lot, because government to the rural sector will be easier for us to use. I think and we have to tell the government, do this. We have to advise the government that, I do communicate to government a lot. Even though I'm working in a private sector, 30 years I've been communicating. I keep writing to them. I keep, writing the right, you have to be the right language. You don't need to really, look at your own interests. It is all about creating communities, reaching out to people. So reaching out to communities and in rural areas. So you have to keep doing those kind of communication too, so that they put it across to the TV and use the phones which we have. And then the quality of communication is the third thing I think is very vital, because you have to reach to the mindset. So many a times we do create communications which doesn't make sense to people. You need to understand, you have to be sensitive to understand the people, and then create the communication which is will be read by and understood by the community where we are talking. So all these things I think are important. We have to keep communicating. We know that awareness generation and using technology has to be mindset change. And I think overall, when the country becomes digital, the way the government talks about digital India, and they also have, I think government has a lot of digital focus in their programs. The more the whole country rises in healthcare, the community also will rise. So they will be taking a little bit of time, because it just we can't just be very smart in one area and the other parts are not even looked up to. The food, the general health, the way we live in the houses, the roads, everything is important. So everything improves. Connectivity improves, the roads are important, the bandwidth is important. Both improves, I think we will also reach to everyone. The dream, we should not miss out on our dreams, that we have to do quality care for every Indian. So the more if we are focused on our dreams, things will happen.
Thank you. So that's very very good insight, especially the regular quality sensitive information or communication passed on to the mass. Yes, that is definitely going to make a change. Now, my next query or question is to Dr. Karanjekar again. So we know after COVID has come in, there is a huge focus on telehealth, and that's one vertical of the digital health which has got very high momentum in terms of the implementation. But in rural settings, we also know that, but there are a lot of other factors to the entire digital health in terms of remote monitoring devices or the IoTs that we talk about, or the data analytics, the predictive analysis, AIs. So a lot of things have come in. But what do you think, other than telehealth, is there any other digital health tool which can really fit into a rural health setting that we as a country or as entrepreneurs, are they trying to develop something which can really fit into the rural setting other than telehealth?
Thank you. I think in the rural health, I was recalling something for last few days when I last went to the bank. I don't remember. Last 2.5 years, not by Corona, but if I have to transfer money, it is within minutes. If I have to receive money, it is within minutes. I have to do something to the, even I remember I had to go to the workshops or my car servicing. At the end of the day, I have to go there by taxi, pay the money and bring back the car. No, that's not required. The link is there. He says, you pay, I will send the car. The thing is that even the vendor, the vegetable merchant, or even the small vendor says that this is my QR code, snap it, pay it. I don't have to do money. So the question is of acceptability. People have become aware and accepted that this kind of transaction can happen. Similar acceptability when it comes to the rural area, it will be much better workout for the healthcare. Now, coming back to the, apart from e-health, what is there? See, we are talking of clouds, we are talking of satellites, which will be providing the bigger bandwidth and everything. I remember about 8 days back or 5 days back, there was a news item by Reserve Bank of India saying that they will develop a system whereby the payment will be made even if you don't have 4G or 5G. The payment system without having a proper bandwidth or not having the internet facility, still you can pay, is something remarkably different. If I have similar facility to be used in healthcare, healthcare has always been follower of science, physics, chemistry, optics, anything, IT, everybody invents and then we use it. We are the user of everything, not inventing everything. So once it is invented by accounts people or the IT people, maybe we'll follow it in our area. Whether it is gastroscopy or anything, robotics, we follow it little later. So this is one area, that is the your cloud computing and internets with the help of satellites is another area. But if I give an example of Corona again, I had few trustees at Surat Kiran Hospital and they were quite serious during that time. We treated the largest number probably in Gujarat and Western Maharashtra for Corona, and whenever required, I used to ask my Mumbai doctors or ICU specialists for second opinion. Either I used to airlift them or, but here the WhatsApp messaging and WhatsApp imaging of the ICU came very handy. I may not have a facility to transmit my signals and all numbers which are there on the monitor to Mumbai to recognize it. I can put it on a camera and transmit it where he can see it, enlarge it, see it, and give me an advice. Ultimately, he's going to see, even if he's physically present, he's going to see. And they have treated almost 15 to 20 patients like that. Out of that, 10 to 12 came out of that. So the thing is that even if I didn't have bandwidth, even if I doesn't have anything, on a mobile, I can take the image and transmit the image. So only internet is not the way of transmitting image, I would say. Transmitting the image are multiple ways which you should be using it. And once you use it and show it to that fellow sitting in front of you, now the technology problem like I experienced today, having been in the city like Mumbai, I experienced this problem. So in rural area, if that fellow he fails, it's a failure. So should not happen. You should have a robust system, show it to him, you show the face of the doctor, ask him to talk to him, get a feel that yes, this works. So if that is there, then it will be there. Again coming to the original point, our colleague Dr. Venkat said about the teleradiology and other thing. Yes, it has been a greatest tool. I remember in Bangalore, few years back, I had been there. There was no radiologist in the main hospital, and still they were reporting from their peripheral hospital radiology within minutes, like somebody sitting in that room. Same thing can happen. Today we do it. PET scan, CT, MRI, everything what I have got here. All rural hospitals, they send it there one and we get a report. So this modality, biochemistry modality, they are transmitted and immediately a report comes to you. But yes, these are limited to the diagnostic and consultation. Treatment-wise, very few people have adventured into doing a remote treatment. Because again, there are limitations of diagnostic tools to be available at a remote place and a medical person using them. Both things happen properly. Probably we are. But I'm very sure that we are on the way of progress, and either it will take 5 years or 10 years. By the time we will be reaching every nook and corner of big city and also the surrounding area. Gradually, we'll go to the smaller cities also. So multiple tools can be used, multiple probably adaptable instruments can be used for this purpose, which will give us the thing, and then later on even treatment modalities can be also useful to us.
Thank you, sir. Thank you so much. I think very nicely you put it, and I think all this combination of tools in terms of the pharmacy delivery, the diagnostics, the teleradiology can be mixed with the telehealth and probably go deeper into the treatment modalities. What you're saying, I think that definitely is going to come up very soon in our country also. So that is very evident from the fact that the recent budget has clearly focused on the adoption of digital healthcare across the country. So that is the next question to the panelist, Mr. Yatish, and this is something which the country has brought in, like the United Health Interface. This is something which they have, the NHA has proposed now to bring in the digital health across the country. So what do you think, how the UHI, which is the United Health Interface, is going to help us in getting the digital healthcare ecosystem across the country?
Well, Dave, getting all your data parameters, everything online will be beneficial in the long run. If you see, unlike the West, India still today, there's still, less than 20% penetration of healthcare insurance. Now, with the digitization of records, with a larger base being made available, you would have healthcare costs going down, a larger base getting insured. Ayushman Bharat also has brought in a significant population that's been covered today. But unfortunately, there's still a huge chunk which is in between the private insurers and who are not really BPL or EWS. So with this spectrum getting enhanced, I think there's a scope for a lot of rationalization. And data mining will sort of really assist in the long term. I don't think anyone sort of has as diverse a population as in India, where even the disease pattern changes from district to district and city to city, where you've got a place like the cancer train running between Punjab and Rajasthan, wherein because of a certain topography in Punjab, you have very high cancer incidence rates. Or for Mathura, where we run one of our facilities, Agra Mathura, where because of eating habits, you have, or practices, general practices, you have very high cervical and oral cancer rates. So with a unified registry, a UHI of sorts, the data repository coming into force, it will aid the process of decision making. It will aid and take forward the journey of medical technology, the use of IoTs, which is just begun. We have not even seen and hit the tip of the iceberg. There's tremendous scope and opportunity that is available today, Dave. Yeah, Dave.
Yeah. Thank you so much. I think you covered a very valid area with the proper insight. So I think we will look forward for the proper implementation of the UHI in India very soon. So I now take it to Dr. Venkat. Probably we have to close the session. We are almost come to the end of the session. We had a lot of questions because this panel also is very very esteemed, and the subject is also so exhaustive. But I think we have a time constraint here. So I go to Dr. Venkat with the last question, which is, how do you think can technology be leveraged to increase the awareness? Behavior is something which Dr. Rupali already mentioned. So I want to understand how can we improve the awareness of the technology among the rural class? Any suggestions from your side, Dr. Venkat?
Okay, awareness of technology, presume it's in relation to the healthcare, right? Because a lot of mobile phone usage has come for digital payments. So in that sense, the healthcare can be extrapolated on the same lines with the usage and the penetration of mobile phones. So again, we are seeing a lot of telehealth being developed on the same platform, using mobile health technology. Doctors sitting in a conference hall, then trying to discuss patients or even surgeries being performed remotely, for example. So all this has been happening. The exciting times are when the insurance people will take this aspect very seriously, because unless our rural populations are insured either privately or with the government, now that Ayushman Bharat is coming up, so unless this happens, and unless that also integrates some technology into that aspect, it's very difficult to really see it going in a proper direction. Because what is happening is, especially in the rural healthcare sector, tertiary care is given a lot of importance. So when a patient has a heart attack or when a patient has cancer, they can get diagnosed. They have limited facilities for treatment, etc., and they may have to come to the big city centers to get their treatment. Essentially, primary care has been non-existent, and this is where technology can actually bridge that gap. Because unless we have a robust primary care, which can be to a large extent taken care of by providing physicians on telehealth platforms, regular blood checkups, basics, etc. Unless that happens, it's very difficult for primary care to go into
I think Dr. Venkat Chandan is giving us a red flag. I think we are the time is up. Sorry, we would be very eager to hear you, but then I'm sorry to interrupt, and
no worries.
Apologies for this intrusion. I think we have a time frame given. I think we have to close it. So, Mr. Chandan, just one thing. I just want to take one question from the audience, which is the PPP model that they were talking about in lowering the urban-rural divide. Just one example I want to give in my place where I used to work in Wayanad. We used to work with the government to take up the rural population, especially the tribal population pregnancies. That's where the government and our hospital partnered together, where we used to provide a free treatment for all the tribal women at our hospital, but all the support till they come for the pregnancy to the hospital is covered by the government at their home, using the Anganwadi workers or the healthcare workers that Ms. Ekta was also mentioning. They will also drop the patient at our place through their ambulance, but treatment is given free from our side. They take back the patient to their home and follow up with them. So it has worked wonderfully well. We could reduce the mortality that used to be present in that district, especially it came in big news and all before we took over that challenge. Tribal women had given birth on the way and unfortunately succumbed. That was a big news, national news. and with our intervention we could bring it to a zero level. That's something which we could do. So PPP has an effective role in bridging that gap, urban rural divide. So thanks to all panelists for a wonderful session. I feel that we still have a lot of questions to answer and a lot more things to come back from your side, but I think there are the next panel is already ready, so I think we should hear it from them. I think Mr. Chandan, thanks for once again for organizing this wonderful panel. Thank you.
Thank you, Chandan. Thank you, Devanand,
Please,
Rupali, and other
Thanks,
team.
Dave.
Thank you very much.
Thanks,
Bye.
everyone.
Please stay tuned with us, sir. Thank you so much. Lovely moderation, Devanandji. In fact, see the kind of topics which we have suggested, we have taken has given a lot of effort in research, and then we have finalized this topic, and then bringing the right stakeholders for the right panel, including. So we want to make this entire healthcare and wellness segment. We want to give every bit part in equal importance. Let it be Ayush, let it be pharma, let it be maybe a wellness community.